And now I am very pleased to introduce our speaker for today. Dr. David Rudman is an orthopedic surgeon with a state-of-the-art office in Bergen County, New Jersey. He is board certified and fellowship trained in sports medicine, shoulder and knee surgery, among other surgeries. Dr. David Rudman will be speaking a little bit more about himself, and we want to thank you so much for joining us, Doctor.
Hey, thank you, Susan. Is there a way, right now, you're the only person that I see. I don't see anybody else that's participating.
Yeah, there's no other way to see the participants. I'm sorry about that.
Okay, all right. Talk to the computer. Okay, I'm going to start sharing my screen then.
Sounds great. It's coming. All right. Almost there it is.
So you can see that first slide?
I sure can. Yes, looks good.
And is there any way to confirm that everybody else can, or if we just assume that they can?
We assume they can, but if anyone can't see it, please just write in the Q&A or chat box for me. All right, I'll let you know if anything comes up. I think it's all fine though.
Great. All right. Well, thanks. You know, it's a little unusual and sort of a strange time what we're dealing with, but I appreciate everybody coming this afternoon or on their computers or on their devices to get a little bit more educated about shoulder arthritis. Susan, thank you for inviting me to participate in this. A couple of years ago, I did this in person and got a very good turnout over at Craft Center. So the talk's sort of been updated since then. I'm going to be talking about shoulder arthritis, everything from anti-inflammatories to replacement. As Susan mentioned, my name is David Rudman. I'm an orthopedic surgeon. My office is in Ridgewood, New Jersey. I did my medical school training at SUNY Health Science Center at Syracuse. I did my orthopedic training in Lenox Hill Hospital across the bridge in Manhattan, where I did orthopedic oncology at Sloan Kettering. I did my orthopedic trauma at UT Southwestern, which is in Texas. And I did my pediatric orthopedics at Boston Children's Hospital with the Harvard program. After I completed my training at Lenox Hill, I went to Denver, Colorado for a year and spent a year with the Broncos and the Rockies doing my fellowship in shoulder, knee, and sports medicine. And that's the majority of what my practice is at this time.
It's confirmed we can see your screen by the participants, Doctor, by the way.
Excellent, thank you. My practice is specialty orthopedics in New Jersey. It's in the, for those of you who are familiar with New Jersey, it's in the old McHugh's building, which is the picture on the bottom left. And I am on, I do a lot of my inpatient and shoulder surgery at the Valley Hospital, currently in Ridgewood, soon to be in Paramus. My goal for today is to be able to discuss with you a little bit about the shoulder anatomy, arthritis, and what it is specifically related to the glenohumeral joint, which is the shoulder joint. We're going to talk about non-operative treatment, as well as operative intervention, and then ending in total shoulder arthroplasty. And again, as Sue mentioned, we'll have some time for questions. So the shoulder joint, I'm going to see if the cursor works or not on this. It does not. The shoulder joint is made up of a ball and socket. There are two joints in the shoulder. If you look, you can at the picture of me, which I think you can see. This is a model of my right shoulder. You look at me, it's just like this. This bone in front here is your clavicle. The wing bone in back is your scapula, and this is your arm, your humerus. There's two joints in the shoulder. This one on top is your acromioclavicular joint, your AC joint. That can get arthritis, but we're not discussing that one today. We're going to discuss this one, the glenohumeral joint. The glenoid is almost flat like a plate. The humerus is round like a ball, which gives the shoulder the most motion of any joint in the body. The picture on your screen on the right is actually showing the shoulder joint open like a book. So you're looking at both faces. You're looking at the glenoid, which is the socket, again, very shallow, and it's covered in articular cartilage. We'll go into more depth about what that is shortly. The humeral head, also covered in articular cartilage, is on the right side of that picture, and again, is nice and round. The name of this slide is It's Not a Cup. I get a lot of patients that come to the office and they say, well, my cup is injured, my rotator cuff. It's a cuff, C-U-F-F. So it's a rotator cuff. And the job of the rotator cuff is to keep the ball in the socket as the deltoid moves the shoulder around. There are 4 rotator cuff muscles. There are 2 on the top. One's called the supraspinatus. The other one's called the infraspinatus. And then there is one in the back, the teres minor, and one in the front, the subscapularis. This is a really good model showing on both sides of the body from the back, showing the anatomy of the deltoid, but also other muscles that are involved in shoulder motion, such as the trapezius and latissimus dorsi. So what is arthritis? This is just a picture showing the humeral head again, covered in a nice shiny white cap, the glenoid covered in a nice. This is the degeneration of this cartilage and the breaking down of this cartilage and what happens during that. Arthritis is not a single disease. There's over 100 types and causes of arthritis. It basically refers to joint pain and joint disease. It affects over 60 million adults a year. It's slightly more prevalent in women. As we get older, it's slightly more prevalent, considerably more prevalent actually. And some types of arthritis can also affect your organs. We're mostly going to be talking about the most common type of arthritis, which is degenerative arthritis. That is an arthritis where your cartilage breaks down over time, which results in pain, swelling, stiffness, loss of motion, that sort of daily discomfort, and startup pain. I'm going to talk a little bit about rotator cuff arthropathy. That's just a definition of an arthritis that comes about when your rotator cuff can't keep the ball in the socket and the ball moves around too much. It wears away all the ends of the bone and the cartilage. And that causes the ball to move around up here, and we have to constrain it. And we'll talk about why that's important shortly. There are several different types of cartilage. Elastic cartilage, which you may know, like that's the cartilage in your ear or your nose. There's hyaline cartilage, which is what we'll be talking about today. That's the articular cartilage. And then there's fibrocartilage, which a lot of people hear about when they say that they tore the cartilage in their knee. They're often talking about the meniscus, which is a cushion inside your knee. So what does cartilage do? What's its function? Well, it maintains the shape and support and structure of a joint. It acts as a cushion between the two bony surfaces, and it really minimizes friction. And cartilage is fascinating because it's smoother and has less friction than ice, and it's pretty amazing. So it's hard to replicate, and we haven't been able to replicate it yet. How does it do this? Well, it does this by it has a complex matrix, and there are different layers. And this is just an example. The reason I put this slide up is because it's made up of different areas of collagen and proteoglycans and aggregans, which are molecules that help attract water. Some repel water, and that's how it gets its strength and sort of sponge-like ability. These things change over time. There's also chondrocytes, which are the cells that help maintain the matrix outside of the cell, as well as the whole the health of the cartilage. This is an example of what it looks like under a microscope with eosinophil staining. You can see on the right, and again, I don't have a pointer. No, it doesn't work. The top part of that is the part that would be closest to the joint. The bottom part of that picture, that really pink part, is actually the bone. So what happens to cartilage over time? Like a lot of things, it dries up and it gets little cracks in it. Those are called fibrillations. The molecules that attract the water and give it the buoyancy and give it its effects and its ability to be so frictionless, they get smaller in size, therefore they attract less water. The collagen that's there gets cross-linked and therefore becomes more stiff, and that leads to decreased tensile strength. So this is a picture of literally what happens with cartilage over time. On the left, you see normal young cartilage with the chondrocytes, healthy extracellular matrix. And as we age, we have something called apoptosis, which is programmed cell death. The extracellular matrix starts to break down. It attracts less water. It sees more load. That causes, when it's seeing more load and the cartilage can't take that load, it causes the bone underneath to see more force. That bone gets more solid and more white. That's called sclerosis. The body says, well, listen, I'm getting too much force. I'm going to make more bone. Those are called osteophytes. And I'll show you some pictures of those shortly. And sometimes underneath the surface, you can get cysts in the bone. And these are all hallmarks of degenerative arthritis or osteoarthritis, what we see on radiographs. So if you have some of this pain and discomfort and you're having, it's most common, then you visit an orthopedist to have an evaluation. A lot of patients sort of start with their primary care doctors and they say, well, listen, I'm having some shoulder pain. I'm sorry, somebody just clicked on. I'm having some shoulder pain. I'm losing some motion. You go visit with an orthopedic surgeon and you have the evaluation. It starts with a lot of history and asking questions. When did the pain start? Was there any trauma? Where is the pain? How long have you had the pain? What makes the pain worse? A lot of patients say, listen, when I get up in the morning, I'm real stiff. I go to reach for something that's stiff. Reaching in the back seat's a challenge. And then what makes it better? Or what makes it worse? And have you had any treatment? Have you tried anything yet? Have you been treated with, for your shoulder in the past? What's worked? What hasn't worked? Orthopedic surgeon will often, you'll undergo a physical exam where we look for symmetry, any bruising or swelling or edema. Then also with the physical exam is palpation. We can push on different areas that help guide us to understand where your pain is, whether it's coming from your AC joint, greater tuberosity, the bicipital region, or the posterior capsule. One of the things with shoulder arthritis is even though it's in the joint, the capsule goes around the whole joint. And the capsule has nerve endings. So sometimes even if you excite the nerve ending here, you'll feel it in the front or you'll feel it in the back. It doesn't always have to be exactly where the pain is. With osteoarthritis, it's very common to feel the pain in the back because what happens is as the shoulder joint wears away, it starts to wear out the back. So if this was the back, the shoulder joint starts to go out the back, and that's where you feel a lot of pain. You'll also be tested for range of motion. That's where we see if there's any symmetry or asymmetry compared to the other side and what your limitations are. We also do strength testing. That helps us figure out if maybe it's your rotator cuff that's the problem. Maybe it's the biceps that's a problem, or maybe you're just stiff. And then there are special tests that help us figure this out, such as the Hawkins and Neer test. And some of you, and most of you, I assume, who are interested in this talk have some sort of shoulder problem and probably have gone through this exam already. As part of your exam, your orthopedic surgeon is going to order radiographs. These x-rays are very helpful. These are actually x-rays of a normal shoulder. So if you're looking at the x-ray on the right, one of the things I want to point out is you can see the ball, the humerus is nice and round. The glenoid also nice and smooth. And you see a space in between those bones. You can see that on the axillary view, which is the one with the arm up like this. And then the scapular Y view, you just see that the ball is lined up in the center. That's the image on the top right. That space is not air. That's where the articular cartilage is. So the cartilage on the glenoid and the cartilage on the humerus. You can't see cartilage on x-ray. So if you start having some joint stiffness and joint pain and slight decreased range of motion, what are your options? What do you do? Well, we often start with modalities. The things that do that are simple are ice. I usually recommend 20 minutes at a time, 2 or 3 times a day. Anti-inflammatories, non-steroidal anti-inflammatories like Aleve, Motrin, Mobic, Celebrex. Those things can all help. Recently, Voltaren gel or diclofenac came on the market as over-the-counter. It used to be prescription only. It's something that it's a gel, you squeeze it on a piece of paper or a pad, and you rub it on the area that it bothers you, and it's just a different method to bring your anti-inflammatories to the area that's bothering you. There's also supplements, and I'll talk about a slide on that in a second. We talk about activity restrictions. Well, we know that immobilization is very bad for the health of cartilage. So if you're just sitting around, that's making it worse. But we also don't want you to be doing things that increase your joint reactive force too much, like heavy weightlifting, and doing a lot of physical activity that's would be considered sort of aggressive. Also physical therapy can help. Sorry. Also physical therapy can help, and I'll show you some slides of that and how that's helpful. The way physical therapy helps is patients often come in with osteoarthritis or degenerative arthritis, and they've lost motion. That means the joint's really tight and stiff and angry like this. So what we do is, if we can get you into physical therapy and doing a home exercise program, we can possibly increase your range of motion, therefore decreasing the pressure on the joint, decreasing the joint reactive forces, hopefully decreasing your inflammation and your pain. These are some general exercises that are just healthy for your shoulder, and even if you're not having shoulder discomfort. So supplements. Supplements are over $1 billion industry. They're not FDA approved. It's just like taking a vitamin. The glucosamine chondroitin sulfate has been big. Turmeric's been big. Osteobiflex, which is a glucosamine chondroitin sulfate. All of these have had their time and it can still be helpful. CBD oils are making a big push now. The truth is, there's not a lot of studies showing how helpful these things are. It seems to be, it's about 50% helpful. In the early stages, it seems to make a difference. In the later stages, it doesn't seem to help much. But it is definitely something that may be worthwhile for some patients that it helps. There's also different injections you can get. I often start with cortisone because it's inexpensive, easily accessible, and helpful. But you can only have a maximum of 3 of those in one joint in a year, and that's because you can have negative effects from the cortisone. Unfortunately, nothing's sort of free. There's visco supplementation and platelet-rich plasma, which has also made the news in the last 10 years and increase in popularity. Cortisone, when we talk about non-steroidal anti-inflammatories like the Aleve, cortisone is a steroidal anti-inflammatory. Your body normally makes it, but we give you a boost of it and we give it to you right in that area. It blocks the inflammatory cascade earlier up in the chain. And this is just showing you a cascade of how inflammation works. It blocks it up here, whereas the Nsaids block it down here. And it can be very, very helpful. Visco supplements, there are a ton of these on the market. Synvisc and Hyalgan are 2 that are popular that I use, but there are many of them. These are a series of 3 injections, 1 a week. Although some have 1 injection, for example, like Synvisc 1 that's pictured here. Again, it depends how early a stage of arthritis you're in. But this adds some longer chains to try to attract more water and make the joint a little bit healthier. This can be repeated every 6 months if it's been beneficial. Platelet-rich plasma, which I'm not sure how many of you know about, but it's PRP. It's part of orthobiologics and progenitor cell therapy, previously known as stem cells. Correctly, it's progenitor cells, but basically what we do is we take your blood, which I do right here in the office. It's in a special syringe and we put it in a centrifuge and we take out this platelet-rich plasma, which increases the concentration of it, and then we inject it back into certain areas. Some science shows certain areas this doesn't help. It has been shown to help with osteoarthritis in the knee. We believe that correlates within the shoulder, but we haven't had great data to prove that yet. This was the studies were done more in the knee, as knee arthritis is something that's been studied significantly more. With platelet-rich plasma, which again I do in my office, and several doctors do, it often is not covered by insurance, so it's an out-of-pocket expense. If you have done a lot of these things and you're still having arthritic pain, there are some times when arthroscopic surgery can be helpful. Arthroscopic surgery is when I make 3 or 4 small incisions about the size of your pinky nail around your shoulder. I put camera inside your shoulder with special instruments, And this can involve just debriding the loose tissue, debriding the loose cartilage, the loose bodies. Sometimes when you get those osteophytes, we can shave them down. If you are stiff, we can do capsular releases, which is under controlled setting. The biceps can be a pain generator. So sometimes if we just release this, we can get you more motion and decrease your pain. And we can do what's called a decompression, where we shave down one of the bones on top, the acromion, to give your rotator cuff more room. And we can also look at the rotator cuff from the top and from the bottom. Shoulder arthroscopy for arthritis is in the late stages has not been successful. In the early stages, it can help. It's usually reserved for the younger patients. In my practice, it is for younger patients. And then we get to, well, what happens if everything else failed? Then we start talking about surgical intervention with open joint replacement surgery. These are pictures of anatomic and reverse total shoulder arthroplasties. We will discuss these. I'm going to use more sort of case presentation style to discuss these different prostheses and how they work. There are more than 100,000 total joints done. This data is old, but I looked it up again. It has not really changed. In contrast, there are about 900,000 total knees done a year in the US. So a significantly less percentage of total shoulders, as we don't need shoulders to ambulate, but we do need shoulders to eat, hygiene, and for quality of life. It's about a little bit more than 50% now. Again, these numbers are a little bit older. Are reverse shoulder replacements. And then there's partial resurfacings, and then revision surgery. On the right is a picture of actually what the prosthesis looks like before it is implanted. The top part of that being the reverse, the bottom part being the anatomic or primary. This is how they look on X-ray after they're done. So this is a case of a patient, CB, who complained of severe right shoulder pain. He was a 69-year-old right-hand dominant teacher at the time. Complained of 8 out of 10 pain, difficulty with his activities of daily living, and he couldn't do a lot of his recreational activities as he was a really big fisherman, and it was really affecting his quality of life. He had tried the things we talked about, like the ice, the anti-inflammatories, activity restrictions, physical therapy, cortisone injections. He had no long-term lasting relief. He did have significant medical problems. And that doesn't preclude you from having a shoulder replacement as long as you are medically optimized. But he had coronary artery disease, even had throat and colon cancer and sleep apnea. He did have stents placed prior, had colon and throat surgery, and did have a left shoulder replacement about 10 years prior. He was on several medications, including cholesterol medication. He didn't have any allergies, rarely drank alcohol, and was not a smoker. Like I said, fishing was his big activity. On physical exam, he was 6 foot, 250 pounds. His right shoulder was tender anteriorly. His range of motion was 120 of forward elevation, 10 of external rotation, and internal rotation reaching behind his back was only to his sacrum. He had pain and crepitance with range of motion and was neurovascularly intact distally and over his axillary nerve distribution. These are his radiographs. And I put these up in contrast to the original radiographs that I put up that were of a healthy shoulder. If you look at the radiograph right in the middle, you can see that his ball is no longer completely round. There's a large, underneath that ball, there's an osteophyte, and there's no space in between the socket and the ball. If you look at the X-ray on the left, I wonder if it's on the left of my screen, if you're seeing the same thing, but if you look at the X-ray on the left, you can see that the ball is a little bit out the back. So this would be centered. It's a little bit like this. That's common in osteoarthritis. Sometimes you will go for further imaging studies. A lot of times that's either that's an MRI, but sometimes it can be a CAT scan. The MRI gives you a lot of information about the soft tissue. If you look at the image on the left, you can see that the ball is no longer round. This is looking at you from an image from the front. And what I'm looking at is that dark stuff is muscle, and then it goes to tendon. So I'm looking at his rotator cuff. And you can just see that this ball is worn away and it's worn out the back and it's no longer round. So his options were to continue with observation. He could try some more anti-inflammatories, ice, activity modifications. He can try other injections or different injections. Or he can try more physical therapy or undergo shoulder replacement surgery. In his case, due to his requirements, his age, and the time of his surgery, he elected to undergo a total shoulder replacement at Valley Hospital. So what that means is one of the risks of surgery, as there are many, but there are risks and benefits, and we have to weigh those in each particular patient. One of the risks is of infection. So we do everything possible to decrease the risk of infection. Often before shoulder surgery, you'll have a special shampoo and soap that we use to wash the area. We have the cleanse for 2 to 3 days, or different cloth wipes. You can shower the morning of surgery. There's no reason to shave on your own. We will take care of that for you. We use a special skin prep at the time of surgery. Sorry, I gotta turn my phone off. At the time of surgery, I use a special table for this, and I use what's called an articulating arm holder. You're sort of, the picture on the right shows the table, but you're not sitting up that high. You're sort of, it's almost like you're on a beach chair or in a recliner. Most commonly, they give you an injection in your neck before surgery, and that makes your whole arm numb. That's called an interscalene block. And since we're doing a lot of this as outpatient surgery now, so it's you come in that morning, you leave that afternoon, the blocks can last 24 to 36 hours. So that's really good for pain relief, and it's really good for meaning you require less narcotics during surgery and less narcotic after surgery. Some patients are concerned with the fact that they go home and after a day they still can't move their hand. Again, it relieves pain, and in this era when we're trying to limit narcotic use, it's been very, very helpful. You do get antibiotics before the operation and before you leave the hospital. We use a special dressing. We use special gloves. We change different things during surgery to make sure that we limit the infection. We use special cement if you're going to have cement. This is often done with press fit. And in a reverse setting, it's screws that hold, that give some of the stability. We use iodine irrigation, which also helps as an antibacterial. Again, we use vancomycin powder at the end of surgery unless you have an allergy. I close the skin usually with skin glue and mesh, which is blocks any bacteria from getting inside. And we use the special Mepilex dressing, which has silver in it, which is also an antibacterial dressing. The risk of infection is under 1% in shoulder replacement surgery. It's a little higher in revision surgery, about 5%. Staph aureus, Staph epidermidis, and Cutaneous acnes are the 3 most common bacteria that cause shoulder infections. This is CB's X-ray and postoperative area. The physical therapy, I point this out because after anatomic shoulder replacement, there is significant physical therapy. It requires the patient to be in a sling for about 6 weeks. That's because we need the rotator cuff. I have to remove part of the rotator cuff to do the surgery, and we need the rotator cuff to heal. So that's protected. We protect your range of motion. But after 6 weeks, you're out of the sling. We work on full range of motion, which is basically the first 3 months. Then about the 8th week, we start some strengthening of your scapular stabilizers and core. And then we work on shoulder strengthening. It is about somewhat, depending on your level of activity, it's about 3 to 6 months before you're back doing everything you want to do before. It really depends on what your previous activity level was. At 6 weeks, when he returned, he had 0 pain. He could elevate already to 95 and was continuing therapy. The plan was to start small fish at 3 months and big fish at about 6 months. These were his x-rays in the postoperative period. And again, you can see the ball is nice and round again. The glenoid in between the bones. The image on the right, the head is now centered. This is, again, just comparing the pre and post-operative x-rays, pointing out what I just mentioned. As on the left side, you see that there's no joint space. There's subchondral sclerosis. That's where the bone gets hard and whiter. You see the little cyst in there, and you can see a little piece of the bone hanging down. That's the osteophyte. Those have all been removed. Had the opportunity to see him recently, being 3 years post-operatively now. Again, the pre-op one on the left, the 3-year post-op on the right shows no evidence of loosening, no change from his prior alignment, and he has no pain. He is back to fishing big fish, and he has more motion than he had prior to surgery, and he is really happy, and it's really improved his quality of life. So take a little pause there for a second. I do see that there are some questions and things in the chat. We'll get to those at the end. So if that's only about half the shoulder replacements or less than half the shoulder replacements being done now, what's the reverse shoulder replacement? What does it actually mean? So again, in a primary, we're replacing the socket with a socket and the ball with a ball. With a reverse, we're making the socket the ball, we're making the ball the socket. The reason we do that is because the rotator cuff isn't functioning, or we think it's not going to function in the future. The reason for that, when we do that, is because this prosthesis works on the power of the deltoid muscle, the big muscle around the shoulder. It keeps it constrained. So if your rotator cuff isn't working and your deltoid fires, your deltoid inserts down here, your head goes up. But if you block that, now your deltoid fires, your arm goes up, your shoulder elevates. And this is just a picture of what the two prostheses look like from a sort of graphic setting, showing the difference of a ball and socket, and then switching the ball and socket on the reverse replacement. This was originally performed and done for something called rotator cuff arthropathy. That's no longer the case, but this is sort of the extreme example of that. And you can see the x-ray on the right, and this is another patient of mine, and I'll show you some of his outcome, but his ball went up so high that it started rubbing against the other bone, the acromion, and sort of wore it away, and it's not articulating in the right spot. So instead of being here, it's up here like this. Rotator cuff isn't functioning. There are different stages of rotator cuff arthropathy and breakdown. Not so interesting for this particular talk, but it's just another way how arthritis has different stages, early, middle, and late. So this is his example. This is preoperative. He's a 68-year-old male, was involved in a motor vehicle accident, did have arthroscopic surgery to repair his rotator cuff, but it did not work. He had 9 out of 10 pain that was constant. He couldn't elevate his arm more than 35, 40 degrees, as you see in this image. It was getting worse. It was affecting his quality of life, his ADLs, and his sleep. His deltoid was able to fire, which was important. MRI did confirm that the supra and spinatus, one of the rotator cuffs on the top muscle, and the subscap, the one in the front, were actually torn, pulled back, and have already atrophied. They have already shrunk it. He elected for a reverse total shoulder arthroplasty. These are his actual x-rays. This is just, again, you can now see there's more space. All the excess bone was removed. The big difference between, one of the big differences between the post-op protocols for primary and reverse total shoulders is that in a reverse total shoulder replacement, you're in a sling for 4 weeks. We move your elbow, wrist, and your fingers. Then we take you out of your sling and we start you on a range of motion program. There's no formal physical therapy required. Usually by 3 months, you have near full or near full of the motion that you will get. One of the, again, unfortunately, nothing's free. So one of the things that you pay for by having a reverse, you get a quicker recovery that's very predictable, but you lose motion reaching behind your back, or what we call internal rotation. This gentleman didn't exactly lose that. This was him at 1 year. You see preoperatively couldn't lift his arm more than 40 degrees. Postoperatively, he was getting up to about 150. Here's a video. This is him at 2 years. Maintained his ability.
And bring him up again for me. Come on down.
His left shoulder is the one that was replaced. And he did very well. This is a picture. The prosthesis have gotten a little bit better over time. The biggest advances have really been in the poly, which is the articulating surface, which is in between these pieces. But these are the two recent shoulder replacements within the last couple of weeks that I did. On the left, you see it's just basically a shorter stem, but again, it's nice and round. There's space. It's in the right spot. On the right, you see a picture of the reverse. Again, it's just a little bit of a shorter stem, preserving bone in the humerus of the arm bone. There are other reasons to do shoulder replacement surgery, and this is just an example of a reverse shoulder replacement for fracture. This case I did recently. Again, you see on the left, this is a 3D reconstruction of a CAT scan. The ball is basically smashed up. I'm sorry, I'm saying that. The ball is broken off. It's in several pieces and it's off to the side. So we elected to replace this. And this is an example of what it looks like on the right. So the goal of my talk was to review with you shoulder anatomy, arthritis, specifically of the glenohumeral joint, and the degenerative arthritic changes or osteoarthritis, the most common. A little bit about the non-operative management and what can be done. And then hopefully you have an understanding that if you require shoulder replacement surgery, a little bit about what to expect preoperatively, operatively, and postoperatively as far as rehabilitation goes, and expected outcomes. So again, I thank you for spending the afternoon with me. This is my family. I still do triathlons, although I haven't been a little over a year due to COVID, but I do sponsor some of the races and around. I think you can see my arrow now. This is me here on the in the middle. I'm going to end my share screen and see if we can get to some of the questions in the Q&A.
All right, thank you so much. It was very comprehensive. We do have a few questions. So somebody had a question about, or they just were mentioning, does extra hydration ease shoulder pain from, I'm so sorry, osteoarthritis away, right? Would that be osteoarthritis?
Yes,
Hydration?
OA.
Mhm.
We abbreviate osteoarthritis. The answer is staying hydrated is healthy for everyone, for everything. We're mostly made up of water. There is a significant amount of water in the articular cartilage. But so do I think you should stay hydrated? Yes. There are studies that show that if you stay hydrated, it directly affects your cartilage. I don't believe so. But I think that everybody should stay hydrated as a rule.
Sure. Somebody was asking, so shoulder replacement has nothing to do with rotator cuff? What if this cuff is damaged? Does that make
Can you ask that question again?
They were asking if shoulder replacement, does it have anything to do with rotator cuff? What if the cuff is damaged? Okay, shoulder replacement.
Right. So if the cuff is damaged, sometimes we can do a primary total shoulder, which is the one where you replace the ball with a ball and a socket with a socket, and we can repair your rotator cuff at the same time. Often, depending on your age, if you're sort of more senior, some say 70 and above, some say 65 and above. The number's kind of going down. Then we would go to a reverse shoulder replacement where it doesn't require your rotator cuff to function. That's the reverse. Again, is the one where we make the socket into a ball and we make the ball into a socket. That doesn't require your rotator cuff. So yes, the rotator cuff is very important in shoulder replacement surgery. If your rotator cuff is damaged or not repairable, then a primary shoulder was going to fail. So we would go right to a reverse.
Okay, thank you. Somebody was asking, can you tell us what spider arm is? Is that a term you're familiar with?
Yeah, so the spider arm is, I don't want to confuse you. That's just basically an extra set of hands in the operating room. It's a device that attaches to the operating table. And we do it sterilely, and it allows me to connect your arm, and I can move your arm around like this in surgery without having an assistant have to hold things. So it's just a spider arm is actually a brand name, but it's just an articulating arm holder.
Okay. Somebody's asking if you could talk a little bit about calcium deposits in addition to arthritis and the treatment after several cortisone injections.
So calcific tendonitis is not necessarily related to shoulder arthritis. Would be a different topic. But if you have failed, a couple of cortisone, several is not what I do in my practice. But if you had failed a couple cortisone, because usually that helps, and physical therapy is not, then often we get further imaging, an MRI to evaluate your rotator cuff. And then sometimes you need arthroscopic surgery to remove that calcification and potentially fix the rotator cuff where that calcification used to be.
Okay, somebody just asked how long do the replacements tend to last?
That's a very good question. So we have data that shows that after 20 years, about 80% of them are still intact and functioning. We think that's going to be longer. However, we don't have the data yet because patients are still, they're still living and they're still in. So we think with the updated prosthesis and the updated polyethylene, the plastic, that they're doing much better.
Okay, great. I know you mentioned a lot of over-the-counter medications. What do you think about Advil? I guess that's one they didn't see that you
Yeah, so Advil, the Advil's fine. It's just the reason I prefer Aleve is Aleve's only twice a day.
Oh,
Advil's every 4 hours.
more often. Okay.
And
And
one of my patients just answered on here. That's
oh
hey,
yeah,
Jane.
I see that. I was just going to read that. So Dr. Rudman did reverse shoulder replacement for me on September 21st. He did a wonderful job, and I totally recommend him to anyone who needs shoulder replacement surgery. He is a great surgeon. Aha, I've heard that many times. That's why you're here.
Thank you. I appreciate that. I try my best.
Yep, absolutely. And just one more question, if you don't mind. What is your feeling about application of heat versus ice, or is any of that helpful, do you find?
So mostly for arthritic changes, if there's inflammation, I prefer ice, and I sort of maintain that. If your joint's really stiff, sometimes the heat can help kind of relax the muscles. But the gentle stretching, I think that seniors in general should have a regular exercise routine, whether that's walking, chair yoga, doing some gentle stretching. Obviously, they have to check with your medical doc and make sure that your heart and lungs can withstand it. But we know that immobilization is bad. Sitting around is not good. So I encourage you to get up and move around. A lot more. I guess that's
right. And is there, I guess it's, is there an age, not age limit, or a time, I guess like an age limit when shoulder repair, when shoulder repair shouldn't be done? What would constitute somebody who wouldn't be a candidate? Maybe
well, I have to say there's not a chronologic age, right? So there's a difference between how old you are and how old your body is, right? So some people, not every 75-year-old looks the same, acts the same, and has the same muscle tone and things like that. So there's no exact cutoff. I will say that after a certain age, and it really depends, if you're over 90, you probably shouldn't be having a shoulder replacement, just because there's risks of surgery and risks of anesthesia. But the answer is no. We can do things up to, if you're physiologically healthy enough, there's no specific cutoff. Repairing your rotator cuff, there is a cutoff for that, because we know if you over a certain age, even if we repair it, it doesn't usually work.
Okay, great. And just one more question. If someone comes to you or, I don't know, how would they find out about how much to exercise the arms and shoulders with some shoulder pain?
Well, again, that's individualized. It's hard to say. I mean, honestly, if you're doing it 3 days a week, I think it's great.
Mhm.
I think that, a lot of my senior patients do a lot of water aerobics. I like that. I like yoga, even if you can't do it on, regular yoga. They're doing chair yoga. They're doing a lot of walking. I encourage them to even walk when it's cold out, because that brings up your heart rate. You got to be careful on the ice. You got to watch out for black ice. You got to be careful doing it when it's too dark. With seniors in general, I don't like uneven ground too much. Sort of common sense, healthy things.
Great. All right. So somebody else said, just want to thank you so much for a very informative session, and it was very helpful to the person. I'm sure many people felt that way. Thank you so much, Dr. Rudman.
My information on specialty ortho, by the way,
Thank you.
if they want to read something else, there's other stuff there too as well.
Okay, what else? What do you say? Medicare, does Medicare cover the procedures?
Yeah, Medicare, yeah.
Okay. Yep.
Yeah,
I
Medicare
know
covers, you mean total shoulders? Yes.
yeah.
It's just the only thing Medicare doesn't cover is sometimes they don't cover visceral supplementation, sometimes, depending on which Medicare you have. And sometimes they don't, and they don't cover any orthobiologic like PRP.
Okay.
Things.
I don't, do you see any other questions that I didn't cover?
The only I see a question, one last question from was the age limit for rotator cuff repair?
Yes.
The answer is no. If you're young and healthy, I can fix your cuff. I
Okay.
usually do this arthroscopically. It's often I only do rotator cuff repairs arthroscopically unless I'm doing a total shoulder at the same time, because I haven't figured out how to do that through the scope. But again, that's what I talk about. If you're over 80, sometimes those repairs aren't really going to work, but it may be worth a try. May not be.
Right.